Good afternoon, friends. Can you see the presentation? Fine. So let us go for the details about asthma. There is a very important organization that is working for asthma, that is known as a Global Initiative for Asthma. It is short form is GINA, and that is working for the making the standard therapeutic guidelines and algorithms for asthma. So this is all the, I think you should try for these guidelines. You can have around, it is if you can go for the latest guideline is around 200 pages guideline. Although many details are there, but yes, it is worth to read. It's good information. So this is what GINA is giving. It gives definition, it gives various diagnosis and classification, various medications, how to prevent, and what are various guidelines for asthma. These are given by GINA. So what is asthma? As per GINA, it is a chronic inflammatory disorder of the airways. Many cells and cellular elements, they play a role into it. It causes chronic inflammation, which is associated with airway hyperresponsiveness that leads to recurrent episodes of wheezing, breathlessness, and chest tightness, coughing. It is widespread, it is variable, and often reversible airflow limitations. So it is major thing is it is a airway flow limitation is there, that is important. How it occurs or why it occurs, that there are certain allergen which takes place. It can be allergen, it can be any compound which is converted into allergen. If you know concept of hapten, then you will realize this. Then they are working at various places. This will cause act on mast cell. It will cause release eosinophil neutrophils, and this will act further. This macrophages and dendritic cell. This allergen will act. They will act on thymus cells, that is Th2 cells, and they will produce various lymphocytes. So this all will contribute in one or other ways, and because of that this will cause increase in the mucus secretion, that is mucus hypersecretion, hyperplasia of the goblet cells, which are, that is increase in the number of cells, we will call it as hyperplasia. So more mucus production, there is a vasodilation and new vessels are formed. Then this mucus plug is there, which is thick in nature, which will be difficult to remove. Then there will be angiogenesis because of this, and this more blood vessels, this will cause more blood, and because of that more mucus will be formed. Then there are various sensory nerves are there, they will be activated. Example, cholinergic nerve, that will be activated, that is cause bronchoconstriction. Histamine will be involved, and this will cause bronchoconstriction, and that will lead to hypertrophy and hyperplasia of the bronchial smooth muscles, airway smooth muscles, and thus it will contribute, thus it will cause decrease or shortening of the lumen. Now how it is there? It can be because of there are, as I told you, there are many things which are responsible. It is allergens, then those which are sensitizers, there can be viruses, it can be air pollutant, chemicals, and particularly these are, when coming to sensitive people, it will cause inflammation, and this inflammation is because of lead to a typical condition where eosinophilic cells are increased. We call it as a chronic eosinophilic bronchitis, that will cause airway hyperresponsiveness. Because of that there will be symptoms like cough, wheeze, chest tightness, dyspnea. Wheeze is a typical sound, you can check with the YouTube videos, that is how the wheezing, just like something blowing pipe malum hai, in earlier days when there were these wooden stoves where there चूल्हे होते थे, तब हवा ये करने के लिए होती थी, उसमें से अगर हवा, तो some whistle like sound was there, that is a wheeze. And various triggers can be known, like allergy, exercise, cold air, presence of this sulfur dioxide particulates. So these are various things which is causing activity. Then these are various inflammatory mechanisms which are there, that is various inflammatory cells are there that will be taking place, that will be causing the action. So example of these are mast cells, then eosinophils, then thymus 2 cells, Th2 cells of this responsible for lymphocytes, basophils, neutrophils, platelets. These are will be playing role whenever they are stimulated. Then various cells like epithelial cells, then smooth muscle cells, endothelial cells, fibroblast nerves, they will play role. And various mediators will act on these like histamine, leukotrienes, prostaglandins, then platelet activating factors, kinins, that is bradykinin and other kinins, then adenosine, endothelin, nitric oxide, cytokines, chemokines, growth factors. These are the mediator which are acting, which result into, so the cells and mediator when come in contact with each other, so this mediator will act on one on other, and accordingly they will produce bronchospasm. Then exudation of plasma, that is plasma is secreted, that will cause more mucus secretion, and then it will cause airway hyperresponsiveness, that is airways will be more responsive and immediately they will start contracting, bronchial constriction, and the structural changes that will cause decrease in the lumen size of bronchi, and this will cause this will make difficulty in breathing. Now once we understand this mechanism, then we have seen already the drugs which are acting on this mechanism at various places. This asthma is very common chronic disease, and around 3 million people are affected. It is prevalence is increasing, and day by day more chances are there because of various environmental and other conditions. So the healthcare expenditure is very high. People are having good mortality and morbidity into it, and it is people cannot work. So if actually you plan about it, that is called as a pharmacoeconomics. That is what is the impact of any kind of disease on person. So person cannot work, so loss of income, then expenses in hospital, stay in hospital, and all these kind of things when calculated, so it becomes very high for these people. So these are various countries where we can see that on the basis of population, in the proportion of population with asthma, how much it is there, and what is the case fatality rate for this. There, suppose there are 1 lakh asthmatic people, how many people are dying? So you can see that is a big one. Then various risk factors which are there, example are host factors, that is individuals which are having hypersensitivity to various chemicals, and they are prone for developing asthma, so the hosts are responsible. And when this type of host, when they come in contact with the environment which is they cannot tolerate, so in that cases they are having the problem, asthma will be precipitated. Here both are required. The host should have that kind of system, that is they are hypersensitive, because there are many people staying in the same environment, they don't have. Okay. And second thing is, when these asthmatic people go in an environmental which is free from these triggers, then they won't have. So these both factors are responsible. The hosts are having that particular kind of what we can say immunological system or inflammatory system, and environmental system nearby them. So both when come together, that will cause asthma. So these are the factors which causes exacerbate. I think exacerbation we have already seen. I'll repeat. Exacerbation is the term which is used for earlier it may be because of certain reason, one or other reason, the person is prone for asthma, but the person is not in the environment of allergens or other such thing, so he may not feel any kind of sign symptom. But as soon as the allergen or anything comes which is causing asthma, then there will be all of a sudden the attack can be there, and it can be very strong one. So this is called as a exacerbation of asthma. So there are various factors that can exacerbate asthma. Example of these are allergens. The person will have allergy of one or other thing. Very common allergens are dust particle, pollen grains, grass, then small insects, this kind of their respiratory infections, or their toxins which are there, exercise and hyperventilation. Whenever exercise is there, person will have more breathing rate, and this more breathing rate, that is we call it as a hyperventilation. So this hyperventilation will result into more air passage, and that can lead to problem. Then weather changes, presence of sulfur dioxide in atmosphere, particularly dry and very cold and dry weather, it causes these attacks of that. Some food, some additives, some drugs can cause these asthma attacks. Now, what are the factors that causes asthma development and expression? So already I told you there are host factors and environmental factors. I told you, and both should be there. When both are there, then and then only this will be matching. So when genetically some people are more prone for that, they are having more airway hyperresponsive. In some genders it is more, obesity wise it is more. So these are the host factors. And environmental factors like various allergens, indoor, outdoor. Indoor means inside the home, maybe termite, mite, then their ped are there, their danders. So these are all indoor allergens. Outdoor are many, as I told you, environment, etc., dust, etc., many are there. Occupational sensitizers, tobacco, smoke, air pollution, respiratory infection, diet, these are various situations. Now we can check it whether it is asthma. If the signs shows recurrent episodes of wheezing, I told you a sound comes while respiration, it is called as a wheezing cough. Troublesome cough at night, cough or wheeze after exercise, cough or wheeze or chest tightness after exposure to airborne allergens. When colds are there, it goes to chest and take more than 10 days to clear, that is cough and cold. So then history and patterns of the symptoms, measurement of the lung function by spirometry, particularly peak expiratory flow, measurement of airway responsiveness. We have seen already spirometry, therefore I have taken it separately so that how it can be useful in comparison of these two. Measurement of airway responsiveness, measurement of allergic status to identify the risk factors. Extra measures may be required to diagnose asthma in children having age 5 years and younger and elderly. How we measure, we have seen already this, that we measure this force expired volume in first second, and normal subject we can see that the dark blue line, that is high, and the yellow line shows which are having asthmatic. And how we separate it from COPD, that in asthmatic patient, when we give bronchodilator, then there will be improvement into it. The FEV will increase, may not be up to normal, but yes, it will be more than without bronchodilator. So bronchodilator can help into asthma. This is very important diagnostic test. If it is not improved, then we can call it as a COPD. So what we have to do, we have to make the patient aware about it, and there should be good communication between patient and doctor, so that patient can receive guidance, patient can identify and reduce the exposure to risk factors, patient can assess, treat, or doctor can assess, treat and monitor asthma, manage the asthma exacerbation, and check it in special considerations. So why the treatment should be there? It should be, what should be the treatment for long term? Because it is a permanent disease almost. So in that cases, what we need is we want to achieve and maintain control of symptoms, maintain normal activity levels including exercise, maintain pulmonary function test so that to check, and we want to make it as close to as normal, we want to prevent the asthma exacerbations, avoid the adverse effects from asthma medications, and prevent mortality because of the asthma, because asthma can be very dangerous. When it is severe, it is not responding. We call it as a status asthmatics. So that becomes very dangerous, and person cannot breathe it sufficiently. Sufficient oxygen cannot go, and there will be hypoxia that can lead to severe problem, multiple organ failures it can cause, and the patient may not able to survive in that condition. So these are various management considerations. So how we are going to do it, various measures are there, so that it can be suppressed and reverse the inflammation with using various treatment, and we should try to make the intervention as early as possible, and the matter should be at multiple ways. One is stopping the exposure, then giving pharmacological therapy, and accordingly go for that, educate the patient. As such, there is no cure for asthma, but one can manage it, as I told you, with a partnership word is used between physician and the patient. That is that helps in control in a very good way. Then there are various educations are there. Will not go in more detail, but all these things should be taught to the patient. Educate the patient continually, educate the family, provide information about asthma, provide training on self-management skill, because many times it can be all of a sudden attack will be there, asthma attack. So patient should be knowing what care and how to identify it is acute severe attack and what care has to be taken. So then make how it should be there. There should be very friendly relation with patient. Patient should not be afraid of talking and sharing the views, dialogues, and should be easy in communication, get feedback. So these are the action plans at one place, how it should be there. Regular treatment is monitored, and what are the problems throughout the day, they are monitored. Whether symptoms are there in a day, how much time it was there, whether it has affected by exercise, whether the person has to wake up during night because of the attack of asthma, then whether now some medication which are emergency medication can be given as a rescue medication. Then all this kind of survey or activities are there, and accordingly patient is asked to do it, and on that basis doctor can have the monitoring and assessment of that. So what are the problem which are, because if the patient is taking treatment continuously, there won't be big problem, but if patient cannot, then we call it as a non-adherence or non-compliance. That is, patient is not remaining adhere to the treatment, is a non-adherence. Adherence means sticking. Adherence is a sticking. Adherence means sticking to the treatment, or compliance means following the orders. So these are almost synonymous word, adherence and compliance. So if the patient is taking it regularly as per the direction, we'll call it as a adherence or compliance. If not, then we'll call it as a non-adherence. Why it can be there? There are two major reasons. Maybe because of the medications, or another is because of the non-medication factors. What are medications? Particularly, most of the time we are asking for the inhalers. So they may not be able to understand how to operate in inhalers. The regimens are complicated. That means morning tablet, afternoon another tablet, evening something different like that. So these are there. Then there are fears about or they have exposed one to other side effects. Then they feel because of this side effect, I will not take medication. Some people are having problem of the cost. Some are having distance to the pharmacy, so that they don't have time to get it, or they cannot reach it. These are all medication uses problem. Non-medication is misunderstanding, lack of information. Just that everything is available, but they feel that there is no need of tablet or like that. Fears about side effects, inappropriate expectations, means they feel that immediately it should be resolved 100%. If it is gradually resolving, they feel that there is no effect, and they may stop it. Underestimation of severity. They do not understand what severity it is there may be, and therefore they may not understand that whatsoever effect is there, maybe it is less but it is useful, then they are not caring themselves about their own ill health, some cultural factors, poor communication. Because of such reasons, these people have the problem and they do not take medication as directed. So various components, we identify this and accordingly reduce this thing. Then second thing is identify the risk factor also. At many places this checking is going on. People do check allergens and other things. So whether it is because of allergens, viral infection, some pollutants, or any drugs concomitantly given. If you know, you have already studied drugs which can cause bronchoconstriction. Anyone can say which drug can cause bronchoconstriction, or which drug can cause exacerbation of bronchial asthma? Anybody? Fast. It can cause bronchial asthma, SABA, which can exacerbate. Exacerbate means which can increase, which was not there earlier. Albuterol is a treatment. In which cases we have seen it as an adverse effect of drug, that it may cause bronchial asthma or it may exacerbate bronchial asthma. We have seen some of the adverse effects. That means you people are not studying anything. Yes, Uzepa, correct. Beta blockers. Aspirin is okay, but beta blockers already we have discussed beta blockers. Any other drug? Common cold medications which contains phenylephrine, which is an okay. So these are various drugs which can cause. Beta blocker are very common doing this. So reducing exposure to some categories of risk factors that will improve the control of asthma and it will reduce the medication need. So these are the various factors, either allergens, viral infection, pollutants, drugs can cause it. So what we can do is we can reduce the exposure to various allergens. We can ask the patient to keep away from tobacco smoke. We can ask person not to go in heavy traffic where vehicle emissions are too much. SO2, we have seen SO2 is mostly from vehicle. Then identify irritants in the workplace, explore the role of infections on asthma development, especially in children and young infants. Then in some cases, influenza vaccination should be provided to the patient with asthma when vaccination of the general population is advised. And routine influenza virus in children and adults with asthma does not appear to protect from asthma exacerbation, but they can stop this flu virus which may contribute. So what are goals of asthma? We want to have good breathing, good normal breathing, and reduction in the difficulties, breathing difficulties. So this is what we want. So the focus is what? Attainment of control correlates with a better quality of life, because quality of life is deteriorated in these people. They cannot sleep properly, they cannot breathe, they cannot exercise, they cannot run, they cannot have too much physical activity, because insufficient breathing causes hypoxia and just like angina like situation, and therefore it can affect cardiovascular system also. So what we can do is determine the initial level of control and implement the treatment, check the patient impairment, then maintain the control once the treatment is implemented, and then check whether there are any adverse effect or not. So we are making the assessment of the risk patient is having, and on that basis we have got various treatments, various stages. So what we are doing, various levels of asthma control. So we have got three major characteristics, either control, partially control, or uncontrolled. If it is controlled, then when we'll call it as a control? When daytime symptoms are twice or less per week. In week, not more than twice symptoms are there. If it is more than twice, then it is partially controlled, and if it is three or more features, then it is more. Limitation of activity, there is no limitation. Can run, can do physical exercise, but yes, feeling is there, identification is there, but in case of, there can be some limitations, and in uncontrolled there are more limitations. Nocturnal awakening, there is no nocturnal awakening or no nocturnal symptoms. Nocturnal here means during night, during sleeping. In partially there can be sometimes, but in uncontrolled there are more. Need for rescue reliever treatment, immediately some treatment has to be given to, once the symptoms are there, to get relief from the symptoms, treatment has to be there. So we have seen twice a week per week, daytime symptoms are there, but when it is more than twice per week, we need some reliever, then it is a partly controlled, and if it is more than three, then it is uncontrolled. Then lung function, that is peak expiratory flow or force expiratory flow in 1 second, it is almost normal. There is a reduction to 80%, and in that it is still more. So this is how we are measuring. We have seen COPD grading earlier on the basis of FE1, FVC values, and we have converted. So similarly here also we are making these various this one, and accordingly we'll make the patient risk, we'll assess it, we'll check the clinical control, check the frequent exacerbations in the past year, then we'll check the admission if required to critical care for asthma, where a patient can be in intensive care. All the things will be monitored, respiration will be done, or forced ventilation can be given. Check whether FE1 is low, exposure to cigarette smoke, high dose medications are there, then we have to give it. And then any exacerbation is there, which should be promptly reviewed for the maintenance of the treatment. So during treatment or even before treatment, if we find that the symptoms are too much, then we should try our best to go for the more treatment to these patients. So we are going for that. We are assessing the asthma control. We are trying to treat it to achieve the control level, and we are monitoring it. We are asking the patient about sign symptom, whether it is in control or not in control. So on that basis, we can go, and accordingly we can adjust the treatment, and it will be continuously monitored. So suppose first time when patient came, we have made the assessment, we have given the treatment. After treatment, we will make assessment, and after that we can go for less treatment or more treatment. If the patient is getting benefit and the symptoms are reduced, then we can gradually, slowly we can taper the doses, reduce the medication. If it is not, then we can add medications. So like that, this monitoring is there, and we are doing it continuously. So we will have stepwise approach for pharmacological therapy. We shall go for step 1, step 2, like that. And why we are going? So that we can have the least possible medication and maximum impact from the minimum medications. So we'll see about it. There are many traditional healing methods are there, but it is not well established. If you know, in India there was very famous thing where they were given some medication with a small fish like that, and that was causing. These were some I have came to know about fish treatment somewhere in Andhra Pradesh or Hyderabad area somewhere. I am not sure. I have read somewhere long back. So these are called as alternative medicine, but nobody knows about exact efficacy about it, and it is not well documented, well proven. Because if you remember, in all therapeutics we have made this, when the things are well documented, then we call it as a recommendations are there, class of recommendation, that is COR 1, 2, 1, then 2A, 2B, like that. So all these class of recommendation, they will be depending on what is the data, how much data we are having for support of it. So let us see level of asthma control. then current treatment, pharmacological property and availability of various form of this treatment, economic consideration. On that basis, the treatment can be confirmed, treatment can be finalized. What are the medications? We call them as a controller medication, which control the severe signs are there, severe problems are there, they control it. So these are known as a controller medications. Example of these are inhaled glucocorticosteroids. Then second are the leukotriene modifiers. Then third one are the long-acting inhaled beta-2 agonist in combination with inhaled glucocorticosteroids. Then systemic glucocorticosteroids, theophylline. Then chromones, that is chromoglycates. आपका सब हो जाए, वहीं रख दो, जो भी है सब वही है. Anti-IgE molecules. So these are the inhaled glucocorticoids. These are various doses. You have already, I think, you know about it. These are the drugs which are used in asthma. We have seen in pharmacology. These are inhaled only. Example of these are beclomethasone, budesonide nebulizer, then ciclesonide, then flinisolide, fluticasone, mometasone, and triamcinolone. These are various there, and for different age group, particularly age less than 5 years and age more than 5 years, different doses are there. That means when it is a local administration, the age less than 5 year is having a different category, and age more than 5 year is a different category. Here we do not wait for child to have age of maybe 17, 18 to become adult. We can give almost adult doses to these people, because this is inhalation. So these are known as all are controlling medication, so which are controlling. We should understand about that. This is the we can say classification based on the actions. So they are controlling, they do not allow the next episode to happen, or they will try to prevent, or we can call it them as a prophylactic medications. While there are medication, we call them as a reliever medication. So already there is a attack of asthma, and in that asthma attack, these agents will do the bronchodilation, and thus they will save the person from that. Okay. These controller medications may not be, they are just supporting reliever medications, but they cannot take part of this reliever medication. So what are these reliever medications? Like rapid acting inhaled beta-2 agonist. You know about various beta-2 agonists. Sava has written one, there are many like that. We have already classified it, Sava and Lavas, isn't it? So what are Savas? That is short acting beta agonist. Lavas are long acting beta agonists. Then systemic glucocorticosteroids, then anticholinergic agents, theophylline, long acting oral beta-2 agonists. So these are various agents which are short and long acting oral or inhaled. So these are various kind of medications which are there. We will call them as reliever. Then we can have in therapy which is specific for various allergens, if we understand what kind of allergen it is, and accordingly we can give it. We can have various immunotherapy, and it can be given along with inhaled corticosteroids, or it can be given additionally, and it has to be done by expert physician. On that basis, this immunotherapy can be given. So let us see what are conditions, and on that basis we shall go for the medication. We will classify into various steps on the basis of controls. We have seen already classifications: control, partly control, uncontrolled, and lastly exacerbation, which is a very dangerous one because it is beyond control. So in control, our goal is there. Why we are doing what is our aim is to maintain and find the lowest controlling step. So in controlling, we are trying to reduce it. In partly controlled, we are considering stepping up to gain the control. In uncontrolled, still we are improving the step, and in exacerbation, it is treated as an exacerbation, that is, it is emergency, and all the efforts should be applied into it. And for all that we can have various treatment steps. That is step 1, which is mild, step 2 is slightly higher step. So every step wise there is a gradually increase in the symptoms and the problem, and accordingly we will have to give the treatment for that. So let us see what are the treatments. So various steps. When we go towards step 1, that means it is a minimum problem, and when we go towards step 5, that means it is increase in the problem, our problem is greater. So in every step what we have to do is we have to give the education to the patient. So all steps, in every phase, our role is giving the asthma education about what is asthma, why it causes, what kind of sign symptom you will have, and what care you should take. You should observe yourself, in what condition it increases, in what environmental it increases, with which kind of food it increases, with which kind of drug it increases, and then accordingly you take care about it. This is all comes as asthma education. Then environmental control. Then once you are educating, then you try to control that. Patient should not go, patient should, which can ask patient not to go. If not smoking, then do not go where the people are smoking nearby, or any other such environment which is there. If it is dust, then don't go in the dusty environment. Wear mask or something like that. So this is how we can control environment. Step 1, the best treatment immediately is the rapid acting beta agonist, and which can be always required whenever it is there, whether it is step 2, step 3, step 4 or step 5. In all cases we will need one rapid acting beta agonist. But if it is step 1, I think it should be help, it should be okay. But when it goes into step 2, step 3, then what will be there? Then along with this rapid acting beta 2 agonist, we can give either low dose, either means any one we have to give, either low dose inhaled corticosteroids, or we can give leukotriene modifier. Leukotriene modifier means, if you remember, we have got two class, if you remember pharmacology, we have got two drugs in that. We have got Zileuton, which causes a decrease in the synthesis, and we have got Zapirlukast, Montelukast, which are antagonist of leukotriene B4. So any of this can be given. Then if the patient goes to if it is in control and if it is nice, it is recovering, then go back to step 1. If it is stable in step 2, continue step 2 treatment. And if the patient still show signs of a problem, is there is increase in the problem, then addition to that, what you can do is low dose this ICS plus long acting beta 2 agonist can be given as a oral therapy. Then or we can give medium or high dose of inhaled corticosteroids, because we have seen corticosteroid can be low dose or high dose. We can give low dose of this steroid, that is inhaled corticosteroid plus leukotriene modifier, or we can have low dose inhaled corticosteroid plus sustained release theophylline. So any of these can be selected in addition to this rapid acting beta agonist in an inhalation form. Then if it is a step 4, then what we shall be doing? Medium or high dose ICS, that is inhaled corticosteroid plus long acting beta 2 agonist. Then in case of still, our option to that is a leukotriene modifier, and otherwise we can have sustained release theophylline. You should note that theophylline has got more adverse effects. In step 5, if still the patient is having, or there are exacerbation, or the patient is getting worse condition, then we can give oral glucocorticoids, start with the lowest dose, and then we can titrate for higher. We can go for anti-IgE treatment, that is treatment against antibodies. This is quite costly. So this is how we can go for this treatment, and then we finalize one by one. So this was what we do in step 1, and we have already classified them. That is, what are step 1, which are having occasional daytime symptoms, they are for short duration, then we'll call it as step 1. And then in that, what we have done, we have done, and the evidence is a good one. Evidence is class A. Then in step 2, the patient which are having the slightly more problem than that. Number of episodes are comparatively more or somewhat more severe. So here we are adding reliever medication plus a single controller we are adding. In first case there was no controller, only reliever medication was there, and we have got good evidences for this all. We have seen this in step 3. Same whatsoever I had told, only now it is encircled and it is again explained in that form. So this is step 3 where what other medications can be done. Then here reliever medication plus 1 or 2 controller we have to add because it is higher step. And then next is treating the asthma into the next step, step 3. There are multiple options are there, that increase medium dose inhaled corticosteroids, which was earlier low dose inhaled glucocorticoids combined with leukotriene modifier. This can also be there, or low dose sustained release theophylline can be there. In step 4, check about it, that is it is a step 2, 3. This is step 4 treatment. So if there is a relief from that, the patient can go and control in step 3, and if it is remaining in step 4 for some time till it is in step 4, go for step 4 treatment. And if it is going beyond step 4, that is reaching to step 5, then we will see that what treatment we have to give. So this is the reliever medication plus 2 or more controllers. हाँ बोलो प्रतिमा. हाँ ले सकते हैं ना, 3 बजे के बाद. मेरा 2 से 3 क्लास चल रहा है प्रतिमा. नहीं 3 बजे से 3-5 के बाद ही मैं क्लास शुरू करूँ. 3 बजे ख़त्म करूँगा. मेरा रूटीन फिक्स है. मैंने शेड्यूल फिक्स कर दिया. 2 से 3 सेकेंड ईयर, 3 से 4 फोर्थ ईयर और 4 से 5 थर्ड ईयर. नहीं मैंने नहीं गैप नहीं, मैंने गैप वगैरह सब बंद कर दिया. 3-5 को अपन है ना. ओके चलो ठीक है. So this is how the treatment is there. Treating for asthma control, we are adding 1 reliever medication plus 2 or more controllers. As our step increases, we can see that we are going to add 1 by 1 number of drugs, and accordingly we are going for step 5 treatment where oral glucocorticoids. This is first time we have introduced oral glucocorticoids because they have more adverse effects, but an anti-IgA treatment which is quite costly. So we can add into it when the other treatments are not supporting. So this is how up to step 5 we have gone for the treatment. When control is achieved, then the ongoing monitor is essential to maintain the control, to check whether it is remaining in that particular stage, it is not going beyond the stage, or rather it will be good if it comes to the lower stage. That is, if it was step 3, then it should come to step 2 or step 1 gradually, then it is a good sign. But if from step 2 it is going to step 3 or step 4, then we want this is not a good sign. Somewhere that means either there is no proper environmental control, no proper thing, or no proper treatment has been taken. Something is wrong, or the person is not responding. So it has to be verified and accordingly go for that. Basic aim is already I told you, we want to go for lowest step possible, because we cannot completely cure it because it is inherently present in the person, but we can make it to, or we can keep it in the stage 1 as far as, or step 1 as far as possible, and with minimum medication. So our 2 things are there: keep it in minimum step and keep in the with the minimum drugs whatsoever possible. So if we can achieve this, then we can successful in making the person quality of life good one. Then when asthma is in control, then we can step down the treatment. As I told you, that is from step 3 to step 2 or step 2 to step 1 we can come down. This is on the basis of this asthma control whenever it is there. Then next is when control in the combination with inhaled glucocorticoids and long acting beta 2 agonist, we have to reduce the dose of inhaled glucocorticoids by 50% while continuing the long acting beta 2 agonist. So when we are adding long acting beta agonist, then our we have to reduce the this inhaled corticosteroid dose by 50%. If control is maintained, we can reduce or to low dose inhaled glucocorticosteroids and stop long acting beta 2 agonists. So this is how we are going down slowly, and I told you every time we have to taper the dose, okay, to reduce the doses particularly of glucocorticosteroids, and no treatment should be abruptly stopped. So it should be gone slowly, less treatment, and accordingly it should go by. Then next is rapid onset and short acting, long acting inhaled beta 2 agonists. They provide temporary relief. So it should be there, and there should be repeated dosing over more than 1-2 days that signal need for the possible increase in the controller therapy. So if this single treatment is not controlling, then we have to increase the controller drugs. I hope you remember now what are the controller drugs and what are the reliever drugs. Reliever are the drugs which are causing relaxation, bronchorelaxation, those which are directly doing it, and control are the drugs which are preventing these attacks. So once we understand this, then we can step up the treatment in response to loss of control. When because of one or other reason we cannot control it, then we go for long acting inhaled beta 2 agonists like formoterol and inhaled glucocorticosteroids like budesonide in a single inhaler, both as a controller and reliever, and that is maintaining high level of asthma control, which can reduce the exacerbation. So this is a good combination of formoterol and budesonide. Then doubling the dose of inhaled glucocorticoids is not effective and it's not recommended. So there is no need to double the dose of inhaled glucocorticoids. They can remain in the normal doses only. However, we can increase the doses of reliever drug or beta agonist drugs. Exacerbation of asthma's episodes of progressive increase in the shortness of breath, then cough, wheezing, chest tightness when there is exacerbation is there. So it is characterized by decrease in the respiratory airflow that can be quantified and monitored by the measurement of lung function. That is, there will be decrease in the PE, that is FE1 and PEF, both will be changing, both will be decreased considerably. Severe exacerbation are potentially life-threatening and treatment requires close supervision. Patient has to be hospitalized in this condition, and oxygen therapy and all, if required, can be started along with that. So treatment will depend on the patient, what kind of patient will be there, experience of the healthcare professional about the patient's treatment, to which drug it responds to, what kind of thing it accepts, therapies that are the most effective for the particular patients, availability of medications, emergency facilities. On that basis, one can go for. Primary therapies for exacerbations are repetitive administration of rapid acting inhaled beta 2 agonist, early introduction of systemic glucocorticoids when it is exacerbation, oxygen supplementation, just now I told you, and closely monitor the response to treatment with serial measures of the lung function. So continuous monitoring will be required. Same is the condition, or same is the treatment thing which is followed in the status asthmatics. So it is very important. It is very severe form of asthmatics. It is severe exacerbation we can call, which is all of sudden, which is a sudden acute and severe attack of asthma, which is not giving response to the normal treatment. You have to go for the additional treatment where we can have systemic this corticosteroid agents plus various bronchodilators, and maybe combination of more than one type of bronchodilator. We know various bronchodilator. What are they? We know beta 2 agonist and other are the muscarinic receptor antagonist. So we may add both, and then it should go for a multiple therapy so that it makes. Special consideration should be made in particularly when there is a pregnancy, because few drugs cannot be given during that when surgery is going on, so some other drug will be given during that, anesthesia will be given. So during surgery accordingly we can have different drugs. Already is having rhinitis, that is normally common cold, we call it as a sinusitis, inflammation of sinuses, that is rather extension of common cold, and nasal polyps, that is some growth is there, cyst like बाहर जैसा मस्सा आता है वैसे अंदर एक आता है, उसको पॉलिप्स बोलते हैं. Occupational asthma, because of the occupation, example painter is there, because of the paint fumes or paint smell having problem. Respiratory infection, because one or other kind of respiratory infection it is there. Gastroesophageal reflux, that we shall study in GIT, that is it is sort of whatsoever in stomach that is coming up in the esophagus, that is called as a gastroesophageal reflux. Then aspirin induced asthma, anaphylaxis and asthma, these are various conditions, and accordingly we have to see that how we can monitor it. Then next is asthma can be effectively controlled in most patients by intervening to suppress and reverse the inflammation, as well as treatment of the bronchoconstriction and related symptoms. There is no cure for asthma, I told you, only we can keep the patient in any one step, that is if we want to keep, we'll be happy if we can continuously keep the patient in the step 1 and without allowing or without making to go into step 2, step 3 like that. Okay. So there is no cure to asthma, only we have to manage it in such a way so that patient do not have any problem, and accordingly continuously guidance and continuously treatment is required. So this stepwise approach is recommended, and accordingly it should help the people. So here we have finished the topic bronchial asthma, various treatment guidelines for the bronchial asthma and how it should be monitored, what are the various medications that can be given. You can go through, you can refer the guidelines, and you can make the algorithms for that, so that it will be easy to understand. You can refer books. If you have any difficulty, you can ask.